Good evening, everyone. Dr. Vanessa Johnston here, Acting Chief Health Officer this week for the ACT. Thanks once again for joining us this evening at this late hour. We've had really good uptake of these previous webinars, and I'm sure the same will be true for tonight. A slightly different focus this evening. We're going to talk less about public health, the public health aspects, I guess, of COVID-19, and more about the clinical aspects of COVID-19. Dr. Naomi Clarke is actually going to give the very brief public health update first off, and then we're going to turn to Dr. Ashwin, Swaminathan, who is going to talk about the clinical features of COVID-19. And then Dr. Nathan Pinskier, who's a GP, is going to talk about, I guess, managing patients in the COVID-19 era, and particularly about the telehealth options. And then I'll come back and facilitate questions. What I generally do is we try and batch them into either public health or kind of clinical questions that might be better directed to an infectious disease specialist or a GP, and I will call on others to provide answers as these questions come in. So without further ado, I'm going to hand over to Naomi Clarke, and I'll see you a bit later on. Thanks.
Okay, thanks a lot, Vanessa. So as Vanessa said, my name is Dr. Naomi Clarke. I'm a public health registrar here at the Health Protection Service at ACT Health. And to start this webinar tonight, I'm just going to be giving a brief update from a public health point of view. So I'll be talking about a brief epidemiological update, reviewing the current testing criteria in the ACT. I'll talk briefly about PPE and also about release from isolation. So I'll just get my PowerPoint slides up here. Okay. So to start with, I'll give an update on epidemiology in Australia. So this slide shows an epidemic curve or epi curve of COVID-19 in Australia up until yesterday, the 7th of April. The blue bars show the number of confirmed new cases each day, and the blue line shows the cumulative total number of cases. So as you can see from this curve, and as you're probably aware, new case numbers have really been decreasing for about the last 10 days in Australia. And that's corresponded with a decrease in, obviously, in the rate of new infections as well. Still, the majority of new infections that are detected in Australia have been acquired overseas. However, we do know that there are localised areas of community transmission in a number of jurisdictions. So there are a proportion of cases for whom a source of infection has not been able to be identified. However, at this stage, we're not seeing an exponential increase in new case numbers as a result of sustained community transmission. And as you can see, we now have approximately 6,000 confirmed COVID-19 cases in Australia. There's been a total of 45 reported deaths as of 6 o'clock this morning, and there's been over 310,000 COVID-19 tests performed across Australia. Moving to the situation in the ACT, so here we've got another epi curve for the ACT by date of notification. As of today, we've had a total of 99 confirmed cases in the ACT, and you can see that the epi curve shows that we're also seeing this decrease in new case numbers. Of the 99 confirmed cases, 47 have recovered and have been released from their self-isolation. 2 of the cases have sadly died. As of this morning, 4 of our COVID-19 cases in the ACT were in hospitals across the ACT, of whom 3 were in intensive care. In terms of where our cases in the ACT are coming from, 79 of our 99 cases were acquired overseas, and that includes on cruise ships. 5 were acquired interstate in areas known to have community transmission or from events where outbreaks have been known to occur. 14 are close contacts of already confirmed cases. And as you may be aware from the media, there is still 1 case for whom we don't have an identified source. We're still working through investigations and doing some testing, and we hope to have some further clarity on that later this week. As of today, we have nearly 5,700 negative tests in the ACT. So most GPs are probably really across the testing criteria, but they are changing rapidly. So I wanted to just briefly review the current criteria for testing for COVID-19 in the ACT. So all patients who are tested need to meet the clinical criterion, which is either a documented fever of 38 degrees or higher, or a history of fever, which is symptoms like night sweats or chills, or acute respiratory infection with symptoms such as shortness of breath, cough, or sore throat. And in addition to meeting this clinical criterion, they also need to meet one of the following epidemiological criteria in order to be tested. So the first is travellers from overseas or from cruise ships if they develop these symptoms within 14 days. Close contacts of confirmed COVID-19 cases, again, if they develop symptoms within 14 days. Healthcare or aged care workers who have recent onset of symptoms, regardless of travel or contact history, which includes anyone who has direct patient contact in a healthcare or aged care setting. Patients who are being hospitalised who don't have an alternative diagnosis to explain their symptoms, and this is at the discretion of the treating team in a hospital setting. People who live in other high-risk settings, such as any residential care facility, boarding schools, military barracks, correctional detention facilities. And then people who have reported links to settings where COVID-19 outbreaks have occurred. And unfortunately, we don't have a list of those settings, but if there's concern that this may be the case for a patient, this should be discussed with Communicable Disease Control at ACT Health. And finally, you may be aware that this week ACT Health is rolling out an enhanced community testing program to try and make sure we get on top of any early community transmission. And in this program, we're testing a random sample of symptomatic individuals who present to one of the ACT respiratory assessment clinics. And these include the walk-in centre at Western Creek and the drive-through testing clinic out at Epic. So people who are symptomatic but don't meet any of the above criteria. If GPs want to test outside this case definition, they are absolutely welcome to do so. However, if you send a patient to the walk-in centre or to Epic, they'll only get tested if they fulfil these criteria. So if GPs want to test outside the case definition, they can collect specimens themselves, or they can send patients to a suitable capital pathology collection centre, and a list of those is available on the Chief Health Officer Alerts website. I wanted to briefly talk about PPE, as I know this is an ongoing topic of concern to all clinicians and practitioners. So as everyone's aware, PPE supply remains a major issue in Australia and also across the world in the context of this pandemic. And ensuring that PPE is used appropriately is a really critical aspect of maintaining that PPE supply as best we can. So yesterday, the Australian Health Protection Principal Committee, or AHPPC, released a statement on the use of PPE in managing suspect and confirmed COVID-19 cases. And in that, they recommended that PPE should be used in managing any patient who has an acute respiratory infection, including those with confirmed and suspected COVID-19. And this is on the background of evidence that in Australia, infections in healthcare workers have generally been acquired when patients have had respiratory symptoms and PPE has not been used. So the specific PPE recommendations for managing suspected and confirmed COVID-19 cases haven't changed, and these were reaffirmed by AHPPC yesterday based on a review of the currently available best up-to-date evidence. So this includes contact and droplet precautions, which includes an impermeable gown, eye protection, gloves, and a surgical mask for any consultations with suspected or confirmed COVID-19 patients. And this includes for specimen collection from patients in the community who have mild respiratory symptoms or no respiratory symptoms. The recommendations for contact and airborne precautions is limited to aerosol generating procedures, as well as care of patients who are critically unwell in an intensive care unit. There is no need for reception staff or other staff within the practice to wear PPE if they're not doing patient consultations. And as before, patients should be screened when they arrive to the practice, ideally from a phone call outside. If possible, if they meet the suspect case definition, they should be given a surgical mask and asked to wait in a single room with the door closed. Or if this isn't available, they can be asked to wait outside, for example, or in their car until the practitioner is available. And finally, I wanted to briefly mention what happens when patients are released from isolation. As you saw, nearly half of our cases have already been released from isolation. There is a fact sheet available about this on the Chief Health Officer Alerts webpage on the ACT Health website. But really the message we want to portray is that this is not a responsibility that we're placing on GPs. For patients who are in the community, Communicable Disease Control at ACT Health will be responsible for clearing these patients to come out of isolation, and that's in accordance with the criteria listed in the national guidelines. Often hospitalised patients will be sent home prior to being released from isolation, and in these situations, again, ACT Health will be clearing those patients for release from isolation. In a small number of cases, patients may be cleared directly from hospital by the treating team. So ACT Health has a system up and running whereby we send the patient's GP a letter advising them that the patient has been cleared for release from isolation after having COVID-19. And we're advising patients to make an appointment with their GP for 7 days after they've been released from isolation. And the purpose of that is for arranging clinical review. And if possible, if this is something GPs are able to do, to organise collection of a serum specimen for storage that could potentially be used for later serological testing. Obviously, patients will need to be informed that this won't necessarily inform their clinical management. And we're asking, if possible, on ACT Pathology's request to collect both an EDTA tube and a serum tube if this is being undertaken. Repeat PCR testing of swabs is not recommended or warranted after patients have been cleared for release from isolation. So that's really all I wanted to talk about this evening. As Adrian said, please feel free to send in your questions via the chat feature. I'll be collating those, and Vanessa will be facilitating a Q&A session at the end. And if there are any questions we don't get to, we're also regularly updating our frequently asked questions for GPs on the Chief Health Officer Alerts webpage. So thank you. That's it from me, and I'll hand over to Ashwin Swaminathan.
Okay, hello everyone. So my name is Ashwin Swaminathan. I'm an infectious diseases physician at Canberra Hospital. I've got my partner in crime here, Sanjaya Senanaki. We're trying to maintain our 1.5 metres of social distance. We took the tape measure out before. We can assure you it's exactly 1.5 minutes. So our role tonight is to go through some of the clinical features of COVID-19 infection and hopefully be able to answer some of your questions at the end. So what is coronavirus or COVID-19? So it is COVID-19 is the name of the disease really, but the virus is SARS-CoV-2. So infection with the virus SARS-CoV-2 is called COVID-19. The virus is from the coronavirus family. It's a single-stranded RNA virus, and it's related to other coronaviruses. So the original SARS from 2002 to 2004, which came from East Asia, and more recently 2009 and onwards, the Middle East respiratory syndrome is also coronavirus, and we're much more familiar with the coronavirus that causes the common cold, one of the viruses that causes that we get every year. The origins of this virus is likely zoonotic. It emerged from live animal markets in Wuhan, the city of Wuhan, and Hubei province in China, as we all know, at the end of 2019. And there's still work as trying to elucidate which animals it might have come from. The risk factors for severe disease. So we know that no one in the world has immunity to this coronavirus. That's a novel coronavirus strain, and that we're all susceptible to getting infection, but some of us are more likely to get severe infection. And the data coming out of China, but also in Italy and the US, where they've been studying this, has been that the risk factor predominantly is age. So, and particularly the elderly, so age above 70, and the risk of mortality goes up almost exponentially after the age of 70, so significantly higher above the age of 80 and 90. Other risk factors are cardiovascular disease and cardiovascular risk factors such as diabetes, or poorly controlled diabetes, poorly controlled hypertension, morbid obesity, chronic lung disease, and cancer seem to be all risk factors. I think that there's further work that needs to be done as to whether these are independent risk factors or whether these are confounding factors in amongst getting older. But certainly these conditions feature prominently in all of the studies. We think that immunosuppressed hosts are more likely to get severe infection, so particularly people who've got significant immunosuppression, organ transplant, for example, recent chemotherapy, that sort of level of immunosuppression. And pregnancy is listed as a potential risk factor for severe complications, particularly if you were to become very unwell and had to go to ICU, then obviously that's not good for a growing baby. Having said that, the studies up till now have not shown that it is a known to cause particularly high birth effects in the third trimester or high rates of miscarriage. So that's an ongoing question. In terms of the symptoms, you would have all heard of these figures of approximately 80% of people with symptoms have mild symptoms, ranging from relatively asymptomatic to a head cold type symptom or a syndrome, and then about 20% needing hospital level support or hospital assessment. So of that 20%, 5% requiring ICU level care. And the mortality in Australia at least is less than 1%, but higher in other regions. And that may be just because we're sort of reporting bias, so we're only detecting the severe cases in Italy, for example. Older people, as I said earlier, seems to be age and advancing age is the major risk factor in terms of severe disease. Children can get this infection, but seem to have relatively mild symptoms or are asymptomatic. The incubation period, the range is 2 to 14 days. There are some case reports of longer incubation periods, but in the main, it's that range. But the median is about 5 to 6 days. We think that asymptomatic infection occurs up to 24 hours pre-symptoms. And obviously this is a concern in terms of the spread of disease. But we think that the infectiousness in that 24 hours prior to developing symptoms is relatively low. In terms of how infectious this illness is or this infection is, we measured that with this parameter called R0, or the reproductive number. And it seems to bounce around depending on what study you look at. Earlier studies had figures closer to 2. Most recent studies and meta-analyses of multiple studies puts the median reproduction factor closer to 3, meaning that for every infected person, they can infect up to 3 additional people. The symptoms of COVID-19 are as listed in this table, which I find quite useful and helps to differentiate against the common cold and the flu. So for COVID-19, fever is very, very common. Up to 80% present with fever. Cough is very common, particularly a dry cough. A sore throat, short dyspnea, fatigue, aches and pains, headaches, stuffy nose occur sometimes. Diarrhea occurs rarely, but interestingly, sneezing is not a feature of this illness, as opposed to sneezing in a common cold, which is relatively common. So there are some commonalities between COVID-19, the cold and the flu, and also some differentiating features. So it shares most features with the flu. The other interesting symptom that is being increasingly reported is anosmia. So the sensation of not being able to smell seems to be relatively common in COVID-19. In terms of the time course of illness, so in the mild infection, it can carry on for a couple of weeks with these symptoms and then sort of dissipates. If people have more severe disease, it does seem to evolve the symptoms in the second week of illness. So this is a study from the Lancet from the Chinese outbreak in Wuhan. This is back in January, where they separated out the hospital population into survivors and non-survivors. And the x-axis here is the number of days of clinical illness. And you can see that both in survivors and non-survivors, fever was fairly prominent up to day 12 or 13. Cough was prominent for a couple of weeks. But dyspnea, so shortness of breath, really emerged from day 7 and into the second week of illness. So really the lung pathology, the lower respiratory tract infection pathology, becomes at least symptomatic, maybe present before then, but becomes symptomatic into that second week of illness. And then the more severe manifestations of infection, ARDS, so acute respiratory distress syndrome, and then effects on heart and kidney, secondary infection really in that second week of infection, and that's when we're seeing the deaths. And people needing to go to ICU is really in that second week. So that's important for general practitioners to know, because you need to know how many days people have been symptomatic for when they present to you. And if they're early on in their symptoms, then they're relatively mild and unlikely to be deteriorating rapidly. But if they're in their second or closer to the day 10 of their infection, then there is a risk of actually fairly rapid deterioration. And the reports of deterioration from being relatively well to being in ICU are occurring within 12 to 24 hours. Those reports are becoming more prominent. And again, you'd worry about that in people with risk factors. So the elderly, people with cardiorespiratory risk factors, cancer, etc. In terms of testing, so Naomi touched on this briefly, the types of tests that we have are imperfect. So one is trying to directly detect the virus. So the test we have for that is a throat and nasopharyngeal swab. The sensitivity we think is around 70%, but the problem is we don't really have a gold standard to compare it with, and it may be the sensitivity of 70% dependent on how we take the swab. The other issue with the test is the turnaround time. So the current assays take some time. So in the lab itself, the lab process takes up to 6 hours. But then if you think about the processing of the sample, the transfer of the sample to the lab, and the reporting it, as you know, it can take up to 24 hours or longer to get that result out. There is a new rapid assay, which is called a Gene Expert, which is the trade name. It's also a PCR, and the turnaround time there is 45 minutes, and it actually doesn't require specialised staff to run that assay. But because this assay is actually coming from the US, there are problems with the numbers of assays that we have access to, and we're sort of dribbling it out. But hopefully, as production of those assays ramps up, we'll get more of those in the weeks and months ahead. You would have also heard about the rapid serology testing. So the IgM and IgG testing is touted as a point of care test and a turnaround time of 10 to 15 minutes. We think that the utility of these tests is probably more for seroprevalence assessment of populations. So understanding what proportion of the population is actually immune, and may be particularly important for healthcare workers and aged care workers returning to work to know whether they're seroconverted. We think there's limited utility in actually diagnosing acute illness. And this is because of when the IgM and IgG starts to rise. So usually from about day 10 onwards, you will see the antibody rise, and that may not be, but a negative test does not exclude acute illness. This is just a couple of slides on what the swabbing kits look like. The first line test is really a combined throat and nasopharyngeal swab for a coronavirus PCR, and it's what we call a flocked swab, which you'd all be familiar with in terms of flu testing. So you really want to get a good throat and nasopharyngeal sample. And on the next slide, there's some pictures of that. We're actually asking for one swab from both. So don't do two swabs, just do one swab of the throat first, and then the nasopharynx with the correct technique, and then putting that into liquid viral media. The next best is, again, doing one swab of the throat and nasopharynx, but then putting it into a dry collection tube. And then if you don't have those particular swabs, those flock swabs, then using a combined throat and deep nasal swab, or just a generic viral swab. In terms of how to do these things, there are some YouTube links there that you can see how to do a swab properly, both of the throat and the nasopharynx. And again, we just need to emphasize that the sensitivity of the test will go up if we've got a good sample. And so I'd encourage you all to watch those videos. They're only very short. We also can have other specimens like sputum. And in hospital, we will test if we can get it endotracheal or bronchoscopic specimens. We can also do stool samples as well, but that's something that we would do in hospital if we're getting negative results from the upper airway and we still strongly suspect the diagnosis. In terms of x-rays, this is what you might find in a severe case of COVID-19 pneumonitis on a chest x-ray, sort of in the second week of illness, where you can see really bilateral airspace opacities, really typical of a viral pneumonia. You can see it looks like cotton wool in both those areas, but it can manifest in different ways. You can get sort of frank consolidation, you can get small effusions, it can be patchy. This is obviously a gross example of someone who's in intensive care with a endotracheal tube in situ, but you can also get this picture of people who are relatively mildly or moderately affected. We don't recommend CT scans, but just for way of illustration, this is a CT scan of someone with COVID-19, and you can see that you've got those bilateral changes. I might see if we can actually run this video. If this works for us. Okay, so this is a CT scan of someone with COVID-19. And if we go through the scan, you can see that the typical features of COVID-19 on CT, so what we call ground glass changes, where it looks like you're looking through ground glass, so like a church window, which is very non-specific changes. You can also get these things called crazy paving. It looks like you've got paved pebbles, and you can sort of see that in this sort of down in this area. And then you can also get frank consolidation as well. So areas here are very, very dense. Opacities are really signs of consolidation. So you can get all of those changes. And so you can get everything from very mild, non-specific ground glass changes, which can be not specific to COVID, could be due to fluid or other infections, and more of this crazy paving and other interstitial changes which are highly suggestive of COVID-19. So we're not recommending that as a screening test, but there is sometimes we need to do that in a hospital setting, or if it's found incidentally on imaging of the abdomen for some other reason, then it may be useful. In terms of assessment, obviously when you're assessing someone, wear appropriate PPE, contact and droplet precautions, as Naomi said, in the main is all that's required because COVID-19 is spread by droplet. So surgical mask, eye protection, gown and gloves. Aerosol precautions are really only, so an N95 or P2 mask and a face shield is really only required if someone is very unwell, with a severe pneumonitis, coughing, packing up their lungs, very dyspneic, or if there's aerosolized generating procedures, so using a nebulizer or high flow oxygen or intubating someone, then those are conditions where you need to use those things, and so not really in general practice, but so we need to do that in hospital. In terms of your assessment, really you want to try to minimise your contact with the patient if you're suspecting COVID, but things that you can do at the bedside with minimal contact is heart rate, respiratory rate, O2 sats. So if you've got an O2 sats probe, then let's put that on the finger and you'll get all of that information. Look for accessory muscle use and assess their conscious state. In terms of general advice, so this is, with general patients coming into general practice, and that we're trying to give advice about how to prevent getting COVID-19 infection. Then we would be recommending vaccination against the flu, if it's available now, and other age-appropriate vaccines, such as Pneumovax, if appropriate. Advanced care planning for the elderly, and really anyone who's above the age of 70 really should have an advanced care plan, or anyone from a nursing home, or anyone with chronic disease, or anyone that you wouldn't be surprised if they will pass away in the next 12 months, should have an advanced care plan, which would be very helpful for us when we're planning about coming to hospital. If they've got asthma or COPD, they really need to have good management plans, action plans in place. And the same goes for chronic disease management planning in terms of their ischemic heart disease or congestive heart failure, diabetes, etc. We need to explain the importance of hand hygiene, cough etiquette, avoiding touching the face, and explain the rationale for social distancing measures. Again, to protect them, but also protect other vulnerable people that might be at home. In terms of mild cases, so if you've got someone who's diagnosed with COVID-19 and they're really in their first week of illness, or they're young and have no risk factors, then the management advice is for them to self-isolate whilst they're symptomatic. Also need to obviously notify public health that you've got a case. And then the rest is really supportive. So rest, encourage oral fluids, paracetamol, review within 48 hours if symptoms worsen, and that can be done by telehealth or in person. And if they need to be given instructions what to do if they worsen significantly, including attending the ED. There is advice on self-care and monitoring of symptoms that you can access on the ACT Health website and also the Australian government website, so you can access those links. In terms of moderate to severe cases, what we're recommending for hospital admission at Canberra and Calvary Hospital is that if someone's got evidence of moderate to severe disease, so if they've got accessory muscle use, if their heart rate is more than 100 beats per minute, if they're tachypneic with a respiratory rate of more than 22, or they're becoming hypoxic, so saturating at less than 94% in room air, and those are indications really that they need to be assessed in hospital. They may still be discharged if they're stable and have supports, but they really should be assessed to whether they need to come in, unless of course there are plans that they shouldn't, if they've got advanced care directives that they're not to come into hospital. If they meet those parameters, then they would likely need to be admitted to our respiratory assessment unit or our COVID ward. So you place oxygen on the patient, and then the decision about how they get to hospital. So if they're in your rooms, then the choice is either calling ACTAS and notifying them of you've got a suspect patient or a patient that you worry about needs to come into hospital. But we're also working on a direct number to call the Calvary or Canberra Hospital for a direct admission so they could bypass ED. And we'll hopefully be able to have that information to you in the next few days as to who you can contact directly so that they can come to the ward directly. In terms of experimental therapies, we're all hoping that there is something that we can use that will reduce the morbidity of this illness, particularly in that severe risk group, people with extreme risk factors. So you would have heard from Donald Trump and others that hydroxychloroquine may have some activity in this condition, and there is relatively strong in vivo data, so test tube data, that it has antiviral properties, but it has had disappointing clinical data in small randomized controlled studies in China and in Europe, but there are bigger studies enrolling patients currently. And there has been use in Canberra and in Australia, but it's really off-label use. Other medications that have been talked about is an HIV medication called Kaletra, so it's a combination of ritonavir and lopinavir. Again, there was a disappointing clinical trial result out of China. It is something that we need to investigate further and maybe part of an Australian RCT. And then there's this medication that was designed for the Ebola outbreak called remdesivir, which again has good in vivo data, but not good clinical data. But hopefully that data will emerge. And there's data coming out almost daily now on other medications that have laboratory evidence. So most recently was ivermectin that I heard about, and Jay will probably know about others. But all of these things really have not been validated in big clinical studies. So there aren't any magical bullets. We're obviously waiting for the vaccine development. But again, that's coronavirus vaccine development is difficult. We haven't had a vaccine against the original SARS or the MERS vaccine, MERS infection, or against the common cold coronavirus. But obviously, global effort now pointed towards this particular problem, and that's what we're waiting for. So that's my last slide, but happy to take questions at the end.
Okay, so thank you. I'm going to take you through how telehealth can work in general practice and in primary care. So when to use, when not to use, when to use it for COVID-10, how to conduct a consultation, how to send clinical documents, and that's proved to be particularly challenging, hardware and software requirements, some risk management, and a little bit about GP and staff training. So the clinical considerations, and we've heard a fair bit about that in the last half hour or so. So essentially, when to use video or telephone consultations, any consultation where there's a benefit to the patient staying at home, and certainly for all COVID-19 related conditions. And a lot of practices are now going through a triage protocol where they're assessing people by phone, and if there's a suspicion of COVID-19, they're asking people to stay at home and they're dialing them in, and whether it's done by telephone or video, that's a matter for the practice, but essentially trying to keep those people out of the practice is really important. And we're very fortunate now to have the telehealth item numbers to support us. Also, telehealth plays an important role when attempting to protect vulnerable populations who are more at risk of contracting COVID-19. Other uses including issuing certificates, repeat prescriptions, prescriptions in general, routine consultations, mental health, counselling, and chronic disease checkups. And that's an area that over the last few weeks has probably fallen away in quite a few general practices. And there's now been an effort with the introduction of the new chronic disease item numbers for telehealth to try and ramp that up. And that's certainly something that's been happening in my practice and many of my colleagues' practices. So in terms of COVID-19, when to use it in telehealth, particularly when the GP or the patient is self-isolating or is vulnerable due to age or medical condition. And they were the original indications for telehealth, original MBS requirements, but however, that's now been expanded. So if the GP or the patient is a confirmed COVID-19 case, the same applies. The GP or the patient has symptoms that could be suggestive of COVID-19, again, telehealth is important. The patient is well or anxious and requires reassurance from the usual practice, again, telehealth plays a role there. And in residential aged care facilities, we're seeing an increased usage of telehealth. And there has been a concern, particularly amongst doctors, to attend residential aged care facilities recently, essentially because of a lack of PPE. So that's a problem I think we're all facing. And the other indication is where there's a need for remote assistance to meet local demand. So sometimes you may be taking on cases that are not actually part of your practice for particular reasons. So when not to use a telephone or video consultation, and essentially I think this is relatively straightforward when you're assessing a potentially serious high-risk condition that requires a physical examination. In the old days, and the old days were only a few months ago, we used to say that the rolled gold process for providing a consultation is a face-to-face consultation with the patient where you can look, touch and feel the patient. Those days have changed and we flipped the model around. So now we're essentially saying that face-to-face consultation should only be provided where there is a need to undertake a consultation that requires a physical examination. So that's the critical requirement, and what we're seeing, I think, in general practice, certainly in the last week and a half, is a substantial reduction in the number of people coming into consulting rooms for face-to-face consultations. In my practice, that's dropped down to about 33% of all consultations, and I'm hearing similar stats from my colleagues as well. So when a patient cannot communicate via telephone or via video, there's no support person available, there might be an issue with the translation or English is not predominant first language. Sometimes it's easier for the person to come in and then you've just got to manage the risks accordingly. And finally, any situation where you doubt the clinical appropriateness of a telehealth consultation, it's probably advisable then to have the patient come in and see you. And one of the critical things about telehealth, and one of the reasons why telehealth has been delayed for so long in Australia, and it's something that we've pushed for the last decade or so, is that there was a concern that there'd be an entrepreneurial increase in the use of telehealth services and that there would be a breakdown in the GP-patient relationship. So one of the critical criteria in terms of the MBS guidelines is that ideally there should be an existing relationship between the patient and either the GP or the practice. And we know that the risks of providing telehealth consultations are reduced when the GP has prior knowledge of the patient's history and access to the complete medical records. So it's been really important that if you're undertaking telehealth, predominantly it should be for generally your patient population. There will be instances, of course, when that's not always possible, but I think that's the rule that we should all be attempting to follow. In terms of the consultation itself, how do you conduct a consultation, a telehealth consultation by phone or video when you may not always be able to see the patient, particularly if it's only done by phone? So ask open-ended questions to gather information. The same principles apply. Avoid medical or technical jargon. And we're all good at introducing three-letter acronyms and other jargon that people and patients don't necessarily understand. So it's important to retain a very common, clear English. Listening and watching for verbal, emotional, behavioural cues are really important. Again, it's a challenge when you're looking at someone down the barrel of a screen. It's hard to maintain that contact, and it's very hard to maintain eye-to-eye contact. Also clarify whether a patient has any home monitoring devices that can assist with a consultation. Have they been taking their blood pressure recently? How reliable is the blood pressure machine, glucose monitoring, weight, and other devices that may assist. Establishing the patient's functional status is also important. So what supports do they have? How are they coping? And finally, determining and establishing an action plan if the patient's symptoms worsen. So if they're not able to be managed by telephone or video, then do we need to then flip to a face-to-face consultation? What's the next process? What we're doing in our practice is essentially adopting a 1, 2, 3 approach. So when a patient rings in to make an appointment, we book them into the appointment system for a particular time. The first consultation we're doing generally is by telephone, not by video. If video is required, then the doctor can flip the video switch on and undertake the video consultation. And then if a subsequent face-to-face is required, well, that will be determined by the consultation. Of course, there are exceptions when the patient needs to come in, so we just go straight to stage 3. In terms of documenting the care, you've got the usual obligations to maintain the patient's record and to document the consultation. So there are a couple of additional features. So where phone and video is used, we need to ensure that the patient consents to this, and then of course you document that as part of the consultation. If there are third parties present, as per normal, you need to obtain the patient's consent, and that can be more challenging in the video or phone context where people are hanging on the end of the phone or they're out of the range of the camera. So it's really important to ask, are there any third parties present? And do you have consent from the patient for that patient's third party to be present through the consultation? The normal process of documenting your clinical findings, your diagnosis, your diagnostic investigations, procedures, medicines prescribed, that's par for the course. Any follow-up, again, documented. If there's any technical malfunction that's compromised the quality and safety of the consultation, again, document that as well. And finally, if the patient is bulk billed, and most of these consultations at the moment are being bulk billed, it's important to ensure that the patient has consented to the assignment of the benefit. Verbal consent is adequate. They don't need to physically sign the document, and it's very hard to have a patient sign a DB2 form anyway, or a DB4 form. So how to manage and send the clinical paperwork after the consultation. So prescriptions have proved to be particularly challenging. And in most states and territories, the requirement has been that a hard copy of the consultation has to be received by the pharmacist in order for the pharmacist to dispense the medicines. There have been workarounds in the past, but the patient generally has to provide a hard copy. We've fortunately been able to convince government to change those regulations both at a federal and state level. And remember, prescribing is actually under the jurisdiction of the state or territory. So what we can do now, and there's a fact sheet now on the Department of Health website, you can ask the patient which pharmacy they usually attend. If you're working in the practice, you can print and sign the prescription as usual. If you're working remotely from home because you're self-isolating or you're at risk, you can print the prescription out at the practice and you can insert a digital signature onto a PDF version. That prescription can then be sent to the pharmacy by either email or text or fax. You can use either one, but you must seek consent from the patient for that to happen, and you must document it accordingly. The original then can either be stored by the practice for a period of 2 years or on sent to the pharmacy. This has really streamlined things and overcome the need for practices to run out and buy stamps and run out and post mail. Now there is one caveat: if it's a Schedule 8 prescription or a Schedule 4D prescription, so a drug of dependency, a benzodiazepine, for example, the pharmacy is still required to be sent the original prescription. How you do that is a conversation you have with your pharmacy, and who pays for the mail is a conversation you need to have with your pharmacy as well. In terms of radiology and pathology, there has been no requirement to sign a radiology or pathology request in Australia now for a number of years. So if you're using e-orders, no paperwork is actually required. If you can send the order up to the lab electronically as part of the creation of the test request, then you don't necessarily need to send any paper. If you are creating paper in the traditional way and printing it out, you can email the request to the patient. Again, if you're doing that by ordinary email, ensure you obtain consent from the patient to use ordinary email. With ordinary email, there is a theoretical risk of interception, and that's why secure messaging was introduced. However, in the current circumstances, the use of ordinary email in this crisis is regarded as perfectly acceptable, but you must obtain consent. The patient can then contact their preferred provider and establish how they'd like the request sent electronically. And again, as I said, email is perfectly okay. And then the patient will just undertake the appointment as per normal. Once again, ensure that all the relevant information is recorded on the request slip or the electronic order. So as I mentioned earlier, given the current exceptional circumstances, email is considered as an appropriate method to send clinical paperwork, provided it's in line with the RACGP guidance on using email in general practice. We've prepared a terrific resource which is available on the college website, which gives you a risk assessment and a matrix and a flow chart. So have a look at that. In an ideal world, we would not be saying use ordinary email. These are exceptional circumstances. You can take additional precautions by password protecting when you send the document, but then you've got to send the password by another medium. And again, that makes it a little bit more complicated. But have a look at the guide. It's on the college website, Secure Communications in General Practice, and just work out what works for you. And as I said earlier, email is perfectly okay, provided you obtain consent from the patient and document that accordingly. Now, question of can you record a consultation? So the default position is that telehealth consultation should not be recorded in the same way that we don't record a face-to-face consultation. However, there are some circumstances where a recording might be appropriate, particularly a still image. And if you do that, ensure that you inform the patient about how the recordings images will be stored, managed, and accessed. Again, once you've taken a photo or an image, it forms part of the clinical record. So you need to work out a way of linking it to the clinical record and storing it in the long term. If you don't, then you create a risk for yourself and you create a problem down the track. Make sure you obtain prior consent from the patient, documented in their record accordingly. Confirm the patient's consent verbally on the camera at the start of the recording or the start of taking the image. Store the recording in the patient's record, and advise the patient that they're not authorized to make their own recording. That's really important. You wouldn't have a patient come into your clinic, sit in your room and record the consultation. So the recording is for the professional to retain a copy of in the record. It's not for the patient to retain a copy. Some of the technical considerations, and these are relatively stock standard. Make sure the space is quiet and fit for purpose. In the early days of telehealth, some practices had dedicated rooms. In the current environment where virtually every consulting room will be doing telehealth and phone consultations, ensure that the room is quiet and fit for purpose. It's private. Plain decor and good lighting is important. So if you have lots and lots of clutter in your room, it's probably a good idea to try and minimize that clutter. Maybe even put up a plain sheet, because it's difficult for people to actually focus on you if there are lots of other things around. Ensure that the technology is fit for purpose. So checking when you're starting, does it work? Put yourself in the role of the patient, dial in, have a look and see what it looks like. It's that old adage, if you sit in your waiting room, you get a much better understanding of what's happening in your practice. Ensure that your systems are set up to prevent interruptions, and ultimately, if your video fails, you can revert back to a telephone consultation. What type of hardware, what type of software? So that is the million-dollar question. In the last couple of months, many of you would have noticed there are literally hundreds of telehealth solutions that have popped up. Some of them are freeware, some of them are commercial. We don't recommend any particular product, but what we do say is ensure that the product is fit for purpose and that you're minimizing the risk of a privacy breach. So privacy and confidentiality are critical. Check with the patient that it's okay to use the service, and just inform the patient again there's a small risk when using telehealth, and ensure the patient is comfortable with that. If you're doing it on a continuing basis, some practices have invested in more high-end equipment, and certainly when the first telehealth initiatives came out years ago, practices spent lots and lots of money buying high-end equipment. It's no longer required. Most of the webcams these days are HD, and as long as you've got a good, reliable internet connection, that should be satisfactory. As I said earlier, test the systems before you start moving into video, and ensure that you've got technical support and contingency plans. And if you're working from home, make sure you've got access to the practice's clinical information system. Talked a little bit about risk management. Again, ensure you have contingency plans for the whole process, particularly around managing distressed patients. In a physical consultation, if somebody becomes distressed, it's relatively easy to stand up and soothe them, have somebody else come in and support them, take them to a spare room. If it happens over a telehealth consultation, it's a lot more complicated. So think about how you'd manage a distressed patient or a patient who becomes distressed through the consultation. Talked about, again, having contingency for technology failure, so I won't repeat that. I've talked about the various software products. There's quite a few. That's a very small list. There are probably another 20 or 30. For those of you that might read Pulse Plus IT, have a look at the list that Kate McDonald has prepared. It's quite exhaustive. We have now trialed 2 or 3 different products in our practice. I don't think anything is perfect, but some are better than others. Also, Health Direct is now rolling out its free version as well. There are limited licenses, but you might be able to obtain a copy of that as well. As part of the process of the consultation, ensure that you verify the patient's identity, so name, address, date of birth, at the start of the consultation. And again, as I said earlier, any third parties present should also be asked to identify themselves. Training is critical, so it's not just something that you can just set and forget. It's important that you start a process where staff and nurses and doctors are all familiar with how to use the system. That you talk about the issues around informed consent and decision-making process, that you can deal with issues around cultural awareness, cultural sensitivity, particularly around recording of images, the presence of third parties, that you have a process to coordinate the consultations. How does it happen? Patient rings in and says, I want a consultation by telehealth. Does it just happen automatically? Most practices are treating it as if they had walked into the practice, set up an appointment time, and then the GP then dials back. How do you ensure that the GPs run on time? What happens if the patient's not there when you dial back? Things to think about. How do I manage that? Can you move ahead to the next appointment? So appointment times are not always precise. How do we manage that in the context where the whole practice doesn't always have visibility as to what's happening? In particular, the reception staff may not know where you're up to. So communicating with your reception staff is critical. We've talked about troubleshooting, and we've talked about communications protocols. So I think that takes me to the end of my presentation. Thank you.
Thanks so much. It's Vanessa back. Thank you very much to Naomi, to Ashwin and to Nathan for those really interesting discussions. Sorry, I'm just getting my video sorted. There I am. No, really, really useful presentations. Thank you. So we do have a number of questions. We have run a little bit over time, but because we do film this and a lot of people watch it afterwards, I'm going to ask all of our presenters to stay on the line. We're going to get through as many questions as we can, and therefore if our participants need to drop off, they can watch this section a bit later on when it's up on the website. So we'll start with the public health questions that we've been collating, and Naomi's going to answer a number of those. I'll answer a few. Then we'll move on to the questions for our other presenters. Okay, thanks, Naomi.
Thanks, Vanessa. So I'm just going to answer some of the public health questions that are relatively straightforward with quite quick answers. So one question was, where should collected serum be sent? And the answer to that is please send it to ACT Pathology and just document on the request form that the serum is to store and possible COVID-19 serology at a later date. Can the follow-up GP appointment at 7 days after release from isolation be via telehealth? Yes, it absolutely can be via telehealth. Is the serum collection at follow-up still required if serum was collected at onset? Yes, and we'd really appreciate getting serum on those patients, especially who had serum collected at onset, so that we can, I guess, look at whether there was a change in the serology over the course of the patient's illness. Has there been a need to do contact tracing in any GP practices to date? So far, no, we haven't needed to contact trace any GP practices within the ACT, which is excellent. Does ACT Health also clear people who are asked to isolate? So anyone that we're aware of who's self-isolating, so anyone that we ask to self-isolate because they're a close contact of a confirmed case, anyone that we're aware of who's in quarantine after returning from overseas, yes, we follow up with those people daily via SMS and we advise them when their isolation period is complete. How many negative tests are required to clear a patient, and what happens if follow-up tests are positive? So the majority of patients will be cleared clinically, and the criteria for that are 10 days after the onset of symptoms and at least 72 hours symptom-free. If patients are having tests at follow-up, which is at clearance, which is predominantly being done for healthcare workers, they require 2 consecutive negative tests taken 24 hours apart, at least 24 hours apart. If the follow-up tests are positive, that's managed by ACT Health, and we advise the patients how frequently to go and get their tests repeated. In the event that there's very, very persistent PCR positivity, then that becomes a discussion between the ACT Health and the treating laboratory. But in most instances, it's just 2 negative tests 24 hours apart. We're asking GPs not to send their patients for further PCR testing once a patient has been cleared from isolation. And the last question I'm going to answer is, should we be using N95 masks when a patient is coughing due to the risk of aerosol spread? Generally, the answer to that is no. We don't recommend N95 masks if patients are coughing. It's only really for those aerosol generating procedures such as intubation and CPR. That said, if a patient's got severe symptoms and has a very productive or frequent cough, we wouldn't suggest that GPs collect specimens from those patients, and we'd instead advise them to send the patient into the emergency department for review and for collection of specimens under aerosol precautions. I think that's all the questions I'm going to answer, so I'll hand back to Vanessa to do a couple of final public health related questions, and then we'll get to the clinical questions. Thanks.
Okay, thanks, Naomi. So some final questions. Please clarify if PPE should be used for all patients with respiratory symptoms. So Naomi may have mentioned that there was an AHPPC statement released yesterday on the use of PPE for healthcare workers. And it did state in that document that all patients that present with that healthcare workers should be using PPE, and that's a surgical mask in that instance, for all patients who are presenting with acute respiratory infection. So for patients that are presenting with, runny nose, for example, then no, that wouldn't be captured. But if someone has acute respiratory infection, the advice is to use a surgical mask. Okay, and why do all patients not need PCR clearance, only healthcare workers? So I guess that's a change in the guidance over the CDNA guidance over recent weeks. And that's really just in recognition that there are some people that persistently appear to shed the virus, but when someone who's had mild illness that's at home and has generally been not too sick and then has been symptom-free for some days, the risk of that has been determined to be really quite low. The belief is that potentially some of that, it's likely that virus is actually dead virus. And if they're not someone working in a high-risk setting, then we don't actually need to PCR clear them. For healthcare workers, I guess it's in recognition that they work with vulnerable individuals. They work in institutions where onward transmission could be very detrimental and could be significant, particularly in hospital settings. So I guess it's just applying the precautionary principle there for healthcare workers and applying just a slightly higher standard for their clearance. And the same is true for people who've been in hospital, because it is recognised that people that are sicker with COVID-19 generally have a higher viral load for longer. If a GP, this is a final question for public health, and then I'm going to start asking, sending some questions Ashwin's way and then Nathan. So if a GP becomes positive, what happens to the practice? If they've been practicing social distancing, can the practice stay open? So this is a really interesting question, and it would really depend on the scenario in which that GP became infected with COVID-19 and whether or not they were working for a significant period of time in the practice, physically face-to-face with patients and other healthcare workers and administration staff in the practice while they were infectious. I think we'd probably take an approach somewhat like we do with schools and shut the practice for a short period while we gather all of the information that we need about who are our likely contacts in that scenario, do a very deep terminal clean of the practice before deciding whether or not to reopen. And in most cases, I think the practice would reopen after a cleaning, but we'd really have to assess the situation should that occur here in the ACT. So now we'll move on to some clinical questions now. And I'm very interested in some of these answers, Ashwin, and maybe Nathan too. So does the cough that is seen with COVID-19, does it become more productive over time? And if that's the case, how do we distinguish this from a secondary bacterial infection?
Yeah, it's a good question. So sorry if people couldn't hear me before. I hope you can hear me a bit better now. So look, the cough, yeah, so the typical cough is dry, and that it's certainly our experience here is that in the first week and a half, it's a dry cough, and it can become productive later, and we worry about secondary bacterial infection in that instance. It is hard to tell. We can see from those X-rays I showed in the CT scans, you can get pretty gross consolidation with COVID-19 infection, and so you're going to be producing secretions that you will be bringing up just with the COVID infection. However, secondary bacterial infection is real, and certainly from the Wuhan experience, I've seen reports of up to 50% of co-infection in people who admitted into ICU with other viruses, but also bacterial infection. So very hard to tell, very hard to tell on imaging, very hard to tell clinically, and we do end up in very sick patients and end up treating them with antibacterials.
Thanks, Ashwin. Given that the test is not 100% sensitive, I think you mentioned 70% sensitivity, when should patients be retested if they remain symptomatic despite a negative initial test?
Welcome to my world. This is sort of a bane that we have in hospital. We certainly, so the test isn't great. The sensitivity is quoted as around 70%, which is probably a function of how we do the test and whether we've got a good specimen, but also whether they're viremic at the time of testing. So the viremia, the viral load changes over time, and so you can get unlucky. And certainly we've seen reports of people who've ultimately tested positive that have had multiple negative swabs. So what we've done here is that we have looked at the pre-test probability. So so someone who's had good epidemiological risk factors for having infection, so known contact, recent overseas travel, being on a cruise ship, etc. And then the clinical history about do they give a history that's typical for COVID, and then we have the luxury of also having imaging. So if they've got a chest X-ray or other imaging which is suggestive of a viral pneumonitis, then one negative swab for us isn't sufficient. If we've got a high pretest probability, we will do another one within 24 hours. And we try and marry all of that information together so that negative swabs plus your clinical history, and if you have radiography, like an X-ray, which you, in general practice you may not have, but we do in hospital, then we put that whole picture together to say whether someone's likely to have it or not. And certainly we've had people in hospital who've been on a cruise ship who've got a typical illness, who we've kept in for another day to be swabbed. And one person we actually sent off a stool specimen for stool PCR. But for the vast majority of people, we've been able to clear them just on one negative swab because they've got an atypical history and no risk factors.
Thanks, Ashwin. And GPs are welcome to call CDC and talk to one of our public health doctors, or indeed, I'm sure one of the infectious disease specialists at the Canberra Hospital who's on take wouldn't mind taking a call if you've got particular concerns about a patient. Ashwin, is there any data on the early use of prednisolone for COVID-19?
I'm not seeing that. I mean, there's certainly been caution expressed in various guidelines about, and particularly the use of steroids in sick patients in ICU setting is thought to be probably not recommended. So I've not seen any data saying that it's protective. One question I think that was raised by in the list there was whether we could use steroids for someone who has an exacerbation of asthma or COPD, and that's a really good question, because I guess the question is, could they have COVID-induced exacerbation of their illness, and that may be the case, but the current guidelines and expert sort of evidence suggests that if you think that steroids is useful in the management of that condition, so inhaled or oral steroids for treatment of that acute asthma attack or management of an exacerbation of COPD, then you should use it as you would normally. Don't withhold it.
What about ibuprofen? There's been quite a lot of media about that. Does that worsen COVID-19?
Yeah, so this is sort of another one of these things that got amplified by a politician tweeting. I think one of the French ministers tweeted about Nurofen, and it sort of became a mainstream story. And I guess there is, a kernel of authenticity about this question, because theoretically, non-steroidal anti-inflammatories like ibuprofen can upregulate angiotensin converting enzyme receptors, which is thought to be potentially important in the pathogenesis of COVID-19 or SARS infection. And so, but the data is not really there. We don't know either way whether it is or isn't, a risk factor. And so there's not general advice to stop it if you're on it. I think that's sort of where we are. It's a bit of an open story at the moment.
Thanks. Another question about whether there's a risk when placing oxygen on a patient of increasing the risk of transmission.
Yeah, so this is a good question too. So this is on the basis potentially of whether we would be aerosolizing SARS, the COVID-19 virus by using oxygen. So we think that just low flow oxygen, so nasal prongs and low flow oxygen that you might be able to get, just 4 litres or something like that, Hudson mask is not sufficient to cause aerosolization. We worry about that in the hospital setting if we're using high flow oxygen, high flow nasal prongs, or non-invasive ventilation, so CPAP or BiPAP, and that has a risk, particularly if you're using BiPAP and you haven't got a good seal on the mask, then there's a risk of aerosolizing, and we recommend against that. High flow nasal prongs, when we're talking up to 40 litres a minute, is also a risk, and so ideally we would only do those measures in a single room with a closed door or a negative pressure room. So really not the environment that you'd have in general practice. One thing we would say though is that you shouldn't use a nebulizer at all. So nebulizers are really out in general, apart from small children, I guess. But in adults, you shouldn't use a nebulizer because that has a real risk of aerosolization.
Oh, unmuting myself. Just a couple more for you, Ashwin, and then we'll move on to Nathan. I guess I might combine these. What about the use of the BCG vaccine, and has quinine sulfate also been used in the treatment of COVID-19?
Yeah, so BCG vaccine, so that's the background to that is that we know that children who've been immunised with BCG have a non-specific protection against various viruses, and we don't quite know why. There's sort of immunomodulatory effect on T cells, we think, so boosting your immune response. And so there's a big trial being sponsored out of, I think it's one of the children's hospitals in I think it's Victoria, trying to recruit a lot of healthcare workers to get BCG vaccination to see whether it might have a protective effect. And again, we don't know. It's based on some theory and a protective effect against various viruses that are similar to COVID, but it's again an unanswered question. And the other one about quinine. So I guess the basis of this question is because of the chloroquine and hydroxychloroquine excitement. So we know that there's been a lot of noise and excitement about whether Plaquenil, so hydroxychloroquine or chloroquine, has antiviral effects, and certainly, sorry, I said in vivo before, but I meant in vitro evidence that potentially those sort of agents are effective through a test tube. The clinical evidence of hydroxychloroquine and even in combination with other medications like azithromycin has been disappointing. There's been one slightly positive study that I've seen coming out of France and a few negative ones now. And it certainly doesn't seem to be the magic bullet that everyone hopes it might be. Why does hydroxychloroquine or chloroquine work? We don't really know. We think it might affect intracellular organelles like endosomes and lysosomes, and affect the ability for viruses to enter cells. And it affects the pH of the intracellular environment, and that's how we think it might be a benefit for viral infection. Quinine works in a different way, and there's no evidence that I'm aware of that anyone's tried it for COVID.
Thanks,
So
Ashwin.
Not the anti-malarial effect that's important, it's this other effect, an antiviral effect that's specific to chloroquine and its variants.
And I don't know if Naomi mentioned, but there was also release of an AHVP statement yesterday on the off-label use of some of these medications, including in the anti-malarial and antiretroviral classes, and it's strongly recommended against the off-label use at this point in time, while more data is coming forward. Okay, thanks, Ashwin. I'm going to turn to Nathan. I've got a couple of questions, Nathan, here for you. One of our participants used an online or electronic radiology request, but the patient was advised that a signed copy was also needed. Can you comment on that?
Yeah, so we did a bit of work on this over the last few weeks because it's clearly difficult to send referrals to patients that are hard signed if you're working in a remote environment. I have official advice from the Australian Digital Health Agency that advises that signatures are not required for either pathology or radiology. The problem is that many providers are not aware of this. I have tested this also with Sonic Melbourne Pathology. Your version is Capital, and they've also advised me of the same. So again, we're trying to get out statements. We'll put them on the college website. Ultimately, we need to communicate with the whole of the healthcare sector so that they're all informed that the signatures are not required.
Thanks a lot. And secondly, any tips on getting x-rays in the community? Many private providers are not accepting patients unless they have a COVID-19 negative test result with them.
Look, this is a real problem. I've spoken to a number of my radiology friends and they're really concerned about being exposed themselves. So there's no easy answer. I think it's just a matter of calling your local radiology provider and ascertaining whether or not they have the appropriate safeguards and PPE in place. The big issue has really been around the lack of PPE, and we know it's a real challenge. I was listening to Professor Michael Kidd at lunchtime today, and he was saying that there is actually PPE being redirected in transit. There was a shipment that was supposed to go to Germany today. It ended up being waylaid in, I think, in Thailand, and ended up heading off to the US. So everybody's competing for the same precious resources. If you can get PPE, that's great. You're more likely to be able to undertake a procedure or a process, and if you can't, it's a problem. So check with your local radiology facility.
Thanks very much. So we are 10 minutes to 8, and I think we've probably talked for long enough. I really want to thank Nathan, Ashwin and Naomi for contributing today. It's been so useful. Once again to Capital Health Network and to Adrian for facilitating and helping us with the IT and putting it all together. Any questions that we haven't managed to get to, we will add to our FAQs that we regularly update. And on that note, I think we'll sign off and say good night and thank you once again.